Mycobacterium tuberculosis, pulmonary TB, and then in the end, I will also be talking about leprosy. So I hope you can see the slides and you can also hear my voice very well. No issues?
Yes, ma'am.
Okay, wonderful. Then I'm going to carry on and I'll take your questions at the end. Okay, because I won't be able to see the chat right now. You can put your questions in the chat, and at the end, I'm going to have a look at all of them and then try and answer all of them. Okay? Okay. So, the slides aren't moving. Okay, excellent. Huh. Okay, okay. So they're carrying on. Okay, so this is the part about TB. So this is what I'm going to talk about. I'm going to talk about the transmission and risk of disease. I'm going to talk about the pathogenesis. Then what is the difference between having a TB infection versus having actually tuberculosis, the disease, right? And then I'm going to discuss the different aspects of TB, the pulmonary TB versus extrapulmonary TB and how it's different. And then how do we diagnose at the current standards of diagnosis of pulmonary TB, as well as TB drug resistance and the definitions of drug-resistant TB and how we treat it. I'm just going to touch upon the treatment of TB because obviously that's a huge area, and then a little bit about prevention and then TB infection control. So let's see, what is tuberculosis? So tuberculosis is an active infection, which means it is the disease condition of having an infection by Mycobacterium tuberculosis complex. So what do you understand by two main things that we've talked about? When we say active, that means there must be something called something which must be inactive at this point. So when we say inactive TB, which obviously refers to having the Mycobacterium tuberculosis bacilli inside the body, but they are not manifesting or they are not causing a disease process. That means whenever we talk about a disease, there's a triangle that we talk about. There are obviously host factors and there are pathogen factors, and of course there are environmental factors. So when we talk about host factors and pathogen factors, pathogen means that the organism has to have some sort of ability to cause damage to the host, right? And those abilities are they are restricted to the organism itself, right? However, when we talk about the disease process, it also entails that the host has to be in such a situation. The host has to have some features which will enable the organism to cause that particular damage. So this is why we're saying the disease tuberculosis is an active infection of Mycobacterium tuberculosis complex, and inactive TB can be there, can remain dormant. Having the tubercle bacilli inside the body does not necessarily mean that you have the disease tuberculosis. So when we say the other thing that this statement refers to is using is infection by Mycobacterium tuberculosis complex. So when we say complex means it's basically related organisms to the Mycobacterium tuberculosis sensu stricto, which is Mycobacterium tuberculosis subspecies tuberculosis, then Mycobacterium bovis, Mycobacterium africanum, Mycobacterium microti, Capri, Pinnipidae, Kinetii, and mungai. So what we're talking about are very closely related mycobacterial species, which form a part of this complex. The most important disease-causing organism over here, and the one that we will be talking about, is Mycobacterium tuberculosis, right? So Mycobacterium bovis comes a close second. It is a related species, and it does cause disease in some susceptible hosts. The word susceptible is also very loaded, and it means कि जो है वो you must have some sort of features which allow this particular organism to cause disease. And this particular organism does not cause disease in everyone, and it can cause disease in some people who are exposed to it. Bovis आपके नाम से ही पता चल रहा होगा कि जो है वो cattle से related है, और usually जो है वो those people who are in touch or who deal with cattle, उनके पास ज़्यादा it's more common in those, and it's also a zoonotic organism. So Mycobacterium tuberculosis complex जो है वो सिर्फ अकेला MTB नहीं है, MTB plus other mycobacterial species which can cause a similar sort of disease, right? So mycobacteria क्या होते हैं? So let's look at this. These are bacteria, true. They are bacteria, but they're a little different from your typical bacteria. The important thing to realize over here is to ye obligate aerobes hai. They require oxygen. They cannot grow without oxygen. And the other important thing to remember over here is that they have lipid-rich walls, which means the walls are greasy, they are waxy, and because of the presence of a very important chemical in them, and that is called the mycolic acid. So when we talk about mycolic acid, it's a long chain fatty acid compound. Is that okay? This is clean, I hope. Fine. Right. Okay, so mycolic acid जो है वो एक long chain fatty acid compound है. When we say long chain, तो इसके अंदर हम बात करते हैं कि more than 40 carbons or so, इतनी बड़ी इसकी chain होती है. So it's highly hydrophobic. Being so hydrophobic, it does not allow water-soluble stains and things to enter. And this is a feature of all mycobacteria, which whether they are tuberculosis MTB complex के अंदर हो या ये non-tuberculous mycobacteria, whatever they are, this is a feature of the genus Mycobacterium. ठीक है. अच्छा, so Mycobacterium जो genus है उसकी सबसे बड़ा feature जो है वो mycolic acid है. And when we say कि जो है ये water soluble चीजों को enter नहीं करने देता, तो our best the way we visualize bacteria we know is through gram stain. Gram stain में सारे components जो है वो water soluble है, बहुत ही ज़्यादा water based है. So we need to remember this कि जाहिर है they will not be visible on gram stain. So we'll have to define it in another way. The other thing that we must remember is MTB complex are those 7 organisms that we're talking about. उनमें जो सबसे important है वो Mycobacterium tuberculosis itself है, and they are the ones, they cause a disease manifestation जो कि easily transmit होती है. Immunocompetent individuals may be like you and me, we can transmit it if we have it, and therefore it is termed as a true pathogen, right? You cannot be just colonized with it. You will have an infection, but this will be you will have the organism, but this will be an inactive, shall we say, presence of the organism. It is not going to be a colonization. ठीक है? I hope you know the difference between normal flora. then you have colonization in which organisms increase in number, but and they're there without causing disease. And then there is actual infection. Infection can be active infection when it is causing active damage to the host tissue, or it may be an inactive infection in which it lies dormant, it is not replicating, versus colonization in which organisms are replicating but they're not causing disease. I hope ये transition बहुत अच्छी तरह से समझ में आ गया, but it's very, very important over here. So the important thing to remember over here is the organism itself is a very slow growing organism. It has it doubles in 18 to 20 hours, and that means कि जब हम culture grow कर रहे होंगे, तो obviously it will require weeks before the colonies become visible. एक organism जब उसका doubling time 20 hours है, तो 40 hours में एक organism से सिर्फ 4 बने हुए होंगे. And exponential growth उस तरह से होती है. So you can imagine that it will take several hundred hours before the colony is comprised of millions of bacteria. एक colony हमेशा जो है, अगर आप देखते हैं, एक colony is comprised of at least 10 raised to power 8 bacteria before it becomes visible to naked eye. And that is why हम ये कहते हैं कि जो है वो weeks की incubation होती है. So let's talk about transmission of the organism. TB is spread from person to person through the air. Okay, as you can see, यहाँ पर जो dots हैं, ये आपके जो है वो droplets show कर रहे हैं. So somebody coughs or somebody speaks while exhaling, तो क्या होता है? We have droplets coming out of nose, out of mouth, and they are suspended within a short distance if they are large particles, which means they are larger than 5 microns. And if they are smaller than 5 microns in size, तो फिर they can travel longer distances. I think इतना तो COVID के 1.5 साल में हमें बहुत अच्छी तरह पता चल चुका है कि what is the difference between a droplet and an aerosol. So aerosols are those very tiny droplets which are smaller than 5 microns in size, and they are so light that they do not settle down. They remain suspended in the air. And because they remain suspended in the air, what happens is that zara sa bhi turbulence hoti hai, that they can travel longer distances. So this is why we say कि TB bacilli जो है, because एक तो ये कि hydrophobic होते हैं, तो बहुत easily moisture lose कर जाते हैं, and they form these tiny droplet nuclei which are smaller than 5 microns in size. And this is the reason why TB can be transmitted through aerosols. आपके पास बहुत कम diseases हैं जो कि aerosols के लिए known हैं, and these diseases are TB, measles, chickenpox. ठीक है, ये 3 आपकी तो known definite हैं, और कुछ जो है वो हम concept ये है कि there is a transition between diseases which can form aerosols and which can form droplets. हर disease जो है वो बड़े करीब वाले जो हैं जो respiratory transmission जिसकी होती है, उसमें close within 3 feet या within 1 meter जो है वो हमारे पास बड़े droplets होके जमीन पे गिर जाते हैं, लेकिन जो smaller dry होके आगे survive कर जाते हैं, तो वो आपके आगे aerosols बनते हैं. So हम यही कहते हैं ना कि dichotomy इतनी नहीं है, ज़्यादातर diseases में there is a transition. Okay, खैर हम अब TB की बात कर रहे हैं. TB में हमारे पास बहुत ज़्यादा transition नहीं है, because it tends to be hydrophobic and it loses moisture and very easily becomes aerosolized and transmit a little further. And this is why हम ये कहते हैं कि TB is very easily transmitted between immunocompetent individuals even. ठीक है जी. So airborne particles 1 to 5 microns in diameter, droplet nuclei बना रहा है. These can remain suspended in the air for several hours, and therefore इसमें वही होता है कि अगर टीबी का मरीज वहां पर बैठ के खांस चुका है और वो चला भी गया है, और अगर वहां पर जो है वो एयर चेंजेस नहीं हुई उस जगह पे, वेल वेंटिलेटेड रूम नहीं है, तो अदर पीपल कैन ऑल्सो गेट इट। ठीक है, जो हमारे पास क्लोज्ड स्पेसेस में ओपीडीज होती हैं जो वेल वेंटिलेटेड नहीं है, वहां पर बहुत मेजर मसाइल हो सकते हैं कि दूसरे पेशेंट्स को लग सकता है और आपको भी लग सकता है, एंड दैट इज व्हाई इट इज सो इम्पोर्टेंट टू टेक केयर। हाँ जी, सो लेट्स टॉक अबाउट लेटेंट टीबी और इनएक्टिव टीबी। व्हाट इज इस इसके अंदर ये है कि यू गेट एक्सपोजर टू टीबी। ज्यादातर केसेस में कोई खास इन्फेक्शन नहीं होता, 70-90% सिचुएशंस में आपके पास कोई इन्फेक्शन नहीं होता है, बट 10-30% केसेस में you get infected, right? And when you get infected, there are two possibilities. First, which is much more common, is that the infection will become latent, which means the host immune response is able to close it off, to make the bacteria dormant, and they never develop TB, and they're not infectious because they have managed to wall these organisms off, not allow them to multiply and therefore transmit. ठीक है जी। ऑन द अदर हैंड एक्टिव टीबी में क्या है, अबाउट 10% केसेस में ये होता है कि उसमें जो है वो पेशेंट्स कैन बिकम इल। In half of these situations, they develop TB within 2 years of getting the organism, and in the other half, they develop TB years later because they initially managed to wall it off or make it dormant, but then due to some insult to their immunity or lowering of their immunity, the walled off focus or the walled off bacteria, right? They are now released, and now they are active again, and they are able to multiply, and therefore cause actual active disease. इस सिचुएशन में हमारे पास जहाँ डिजीज होती है, तो if the patients remain untreated, which means अगर natural course of disease हम देखें uninterfered, natural course of disease में about 50% जो है they will die within 5 years if they are untreated, but a quarter of them can remain sick and not die off, and therefore become the perfect host for the organism. You know, they're causing disease and yet they are transmitting, and the host remains alive. It's a good culture medium for them, and they can spread and propagate. On the other hand, a quarter of them recover on their own simply because कि उनका जो है वो immune system recover कर जाता है, and therefore is able to wall off the disease or close the disease itself, right? On the other hand, if you treat the patient can become cured. ठीक, और इसके अंदर हमारे पास जो है वो 100% की बात नहीं होती, हम जो है वो बात करेंगे डिपेंडिंग ऑन कि व्हाट इज द रेजिस्टेंस पैटर्न एंड द प्रोबेबिलिटी। हमेशा कोई भी चीज लाइफ में जो है ना वो 100% नहीं होती है. We all talk about probabilities. So when we say cured, so we mean that if it is susceptible to drugs, you know, and you're taking the drugs properly, हम उसके features की बात करेंगे कि क्या factors हैं जो cure में result करते हैं. Right? So active TB में हमारे पास जो है वो active infection है, and it is the disease, and the disease is called TB, and it needs proper diagnosis and proper treatment. On the other hand, when we talk about latent TB, let's revisit latent TB. And when we talk about latent TB, we say it is not tuberculosis the disease. It is not tuberculosis the disease, because disease के लिए जो है वो active disease process होना चाहिए. It does not necessarily require diagnosis and treatment simply because you've managed to close it off. It's just like के हमारे throat में streptococcus pneumoniae है. It's sitting there. It's not causing disease, and therefore you don't need to diagnose and you don't need to treat it. ठीक है, ये वही वाली चीज है कि you may have Mycobacterium tuberculosis. It's also a pathogen, but it's latent and it's closed off. It's not causing disease. You don't need to diagnose and you don't need to treat it unless कि आप जो हैं एट रिस्क मरीज हों, जिसके अंदर हम प्रीएम्प्ट करते हैं कि ये इसमें हाई प्रोबेबिलिटी ऑफ डेवलपिंग एक्टिव डिजीज इन अ फ्यू इयर्स है, एंड दैट मीन्स कि आप जो है वो प्रॉबेबली इस सिचुएशन में आ जाएंगे कि जो है वो मैनी इयर्स लेटर आप डेवलप करेंगे, या विद इन 2 इयर्स, मैनी इयर्स भी नहीं, विद इन 2 इयर्स आप डेवलप कर लेंगे। तो उस केस में फिर ट्रीट किया जाता है, एंड दैट इज व्हाई उसको डायग्नोज करने के लिए हम कुछ एफर्ट्स करते हैं, एंड दैट सिचुएशन उसके अंदर डायग्नोज करने के लिए कुछ चीजें हैं विच आर मोंटो इंटरफ्रॉन गामा रिलीज एसे, विच इज बेसिकली योर ब्लड इज टेकन आउट, एंड उसके अंदर हम देखते हैं कि क्या आपके वाइट ब्लड सेल्स जो हैं वो सेंसिटाइज्ड हैं against TB bacilli, specific antigens के against, and अगर वो वाकई में sensitized होते हैं तो these cells will release certain chemokines and interleukins, and those can be measured, and if they are in a detectable and in a measurable range और उनका adequate amount होती है, तो फिर हम ये कहते हैं कि ये patient sensitized है, इसमें latent TB है। However, हर एक में नहीं करना है हमें, and that is a very very important thing. The reason why I'm talking about this right now is कि in endemic countries like ours, जो हम दुनिया में नंबर 5 हैं टीबी के लिए, तो टीबी बर्डन के लिए, तो लिटरली आप हर आदमी जो है वो हम कहते हैं कि सेंसिटाइज्ड है और probably has latent TB, almost a huge proportion of the population has TB bacilli in them. However, and obviously that means कि आपको जो है वो हर आदमी को जो है वो latent TB diagnose करने की जरूरत नहीं है, because it's so common, and only the effort to diagnose this should be made in those people जिनकी high probability होती है to develop the disease within 2 years. I hope this is clear. ठीक है? And those people who will develop disease within 2 years are patients, say, of HIV, patients of diabetes, ठीक है, और uncontrolled diabetes खास तौर पे, not just diabetes but uncontrolled diabetes, and debilitated illnesses like SLE है, rheumatoid arthritis है, anything which entails frequent immunosuppression, your patients with transplant, or malignancies, they have a tendency to जिनकी immunity lower हो सकती है, and therefore there's a high probability के active disease को reach करेंगे. So that is why हम ये कहते हैं कि जो है वो ये जो लेटेंट टीबी की डायग्नोसिस है वो सिर्फ और सिर्फ उनमें यूजफुल होगी. Right, now let's get to the actual disease pathogenesis, and it's a very important aspect that you should know how the tubercle bacilli cause disease. So pathogenesis के बहुत सारे certain steps हैं. एक तो ये कि organism की entry हो, किस तरह से entry हो रही है? Through respiratory, वो inhale करते हैं, ठीक है, inhale करते हैं, that means it goes through the airway. Tiny particles हैं less than 5 microns in size, and therefore इनकी transmission जो है वो ना सिर्फ upper airway तक रहती है, but it goes down to the lower airway and it can diffuse into the alveoli. So हम यही कह रहे हैं कि droplet nuclei containing the tubercle bacilli are inhaled, they enter the lungs and travel to the alveoli, and this is where the action is. Okay, and so this is why we've enlarged it, and this is what we're going to say कि आपके पास bronchiole और alveoli तक पहुंच गया है, यहाँ पे tubercle bacilli है, and यहाँ पर जो है वो it can your next step is entry हो गई है हमारे पास, next चीज is attachment. ठीक है, attachment, that means it is going to attach itself to the alveolar membrane. वहां पर आपके certain receptors होते हैं, उनके साथ attach हो जाता है. Attachment के बाद हमारे पास next thing is multiplication. Multiplication in adequate numbers. जब हमारे पास adequate numbers हो जाते हैं तो फिर उसके बाद हमारे पास invasion शुरू होती है. How do we go about that? Let's have a look at this. So this is what happens. क्यों कैसे invasion होती है? Because they are stuck to the सिक्रीशंस जो हमारे पास फ्लूइड है एल्वेओलर जो फ्लूइड लाइन कर रही है एल्वेलाई को, उसको स्टक हुए हुए हैं, वहां पर मल्टीप्लाई कर रहे हैं. उसी तरह से हमारे पास सिचुएशन ये होती है कि दे आर इंजेस्टेड बाय द एल्वेओलर मैक्रोफेजेस. वहां पर क्या हुआ, द मैक्रोफेज ऑब्वियसली फॉर्म्स अ फेगोसोम. ठीक, वहां पर आप the bacilli, mycobacterial tuberculosis bacilli are inside the cells. They're there. अगर यहाँ पर एक्टिव टीबी का प्रोग्रेशन होगी तो they will be able to multiply inside and out of the cells easily. फेगोसोम के अंदर भी आराम से मल्टीप्लाई करेंगे और increase themselves in number, but obviously because of their certain antigens or the presentation of those antigens, the T cells, unke specific T cell clones will be activated against them, and therefore they will release several chemokines and interleukin. खासतौर पे interleukin जो cell mediated immunity का interleukin होता है वो हमारे पास IL-1, TNF alpha वगैरह, वो तो मैक्रोफेजेस रिलीज करते हैं. लेकिन उस अपार्ट फ्रॉम दैट जो स्पेसिफिक IL-12 रिलीज होता है फ्रॉम टी हेल्पर सेल्स. टी हेल्पर सेल्स जो है वो फिर हमारे पास स्पेसिफिक क्लोन्स ऑफ टी साइटोटॉक्सिक टी सेल्स यानी कि CD8+ वाले उनको स्टिमुलेट करते हैं एंड IL-12 IL-2 के थ्रू. और फिर उसके बाद जो है वो हमारे पास रिक्रूटमेंट होती है उनकी around in that particular site, and because of that recruitment आपके पास जो है वो they will release certain chemokines and TNF alpha, interferon gamma, which will convert which will activate your existing macrophages or recruited macrophages, और उनको जो है वो change करेगा into epithelioid cells. वो बड़ी specialized formation होती है, and therefore there will be a development of your typical granuloma, right? और ये granuloma जो है वो हमारे पास will be unable to close off or wall off the bacteria, and that is when we say कि active disease चल रही है और वो multiply कर रहे हैं और granulomas form कर रहे हैं. फिर भी जो है वो हमारे पास the bacilli cannot be limited to that particular, तो वहां पर spread होता है, वहां से भी निकल रहे होते हैं. Then again, अगर on the other hand we have a situation in which the phagosome जो है वो is the bacteria उनके against जो immune cells and वो होते हैं cytotoxic 8 cells, they are able to elicit apoptosis mediated cell death in the macrophage. वो activate हो जाती है जो apoptosis genes होती हैं, ठीक है. So through certain chemical mediators and triggering of cellular pathways, so it can actually result in apoptosis mediated cell death. उसमें भी TB bacilli release हो सकते हैं, लेकिन जो है वो it can TB bacilli release नहीं हो सकते because they also die off with the cell because they had been walled off in phagosome. The other thing that can happen is कि host immune response within the cell क्या होता है कि जो है you have autophagolysosome, which means कि जो phagosome है वो fuses with the with the active endosome, और वहीं पर ही जो है वो हमारे पास fuse होता है within the cell, it dies off, right? The bacilli, so they are dead or at least dormant, right? They are unable to multiply. The other thing that can also happen is कि MTB eradication हो सकती है phagolysosome के through, और इसके अंदर lysosomal fusion होती है, और वहीं पर जो है वो हमारे पास actually dormant नहीं होते, they die off. So there are 3 possibilities कि जब हमारे पास immunity adequate होती है तो the bacilli can either die off or become dormant. The other thing is when it actually जो बिल्कुल dormant हो जाते हैं या completely unable to multiply, वो है situation when the host response is adequate and they're not alive anymore. The other situation is when it becomes latent TB, in which the granuloma that forms is successful in वॉलिंग ऑफ द बैसिलाई. वही वाली चीज के यहाँ पर ग्रैनुलोमा और एपिथेलियोइड सेल्स और ये सारी चीजें फॉर्म तो हो रही थी, बट दे वर स्टिल अनेबल टू विन अगेंस्ट द mycobacteria, and they were still multiplying and still escaping from these granulomas. On the other hand, if the granulomas are able to wall it off and limit the spread, then it becomes latent TB. ठीक है, अब यहाँ पर जो है वो the mycobacteria are not dead. They are quiet, they're not multiplying, and they're just sitting there biding their time. Okay? So this is about 90 to 95% of MTB infected individuals who get a latent disease. ठीक है जी. अब हमारे पास ये है कि अगर ये यहाँ से निकल गए माइकोबैक्टीरिया, तो हमारे पास मोस्ट कॉमन एरिया जहां पर ये मल्टीप्लाई करते हैं वो तो लंग इटसेल्फ है. सही. सो एक साइड की लंग है और फिर उसके बाद हमारे पास the most conducive other area is the other side of lung as well, the other lung as well. The favorite area within the lung is obviously the apex, जहाँ पर oxygenation ज़्यादा होती है, because they are obligate aerobes, as we said. The other thing it can happen is कि यहाँ से ये blood stream में दाखिल होकर other organs की तरफ भी जाएं. And when they reach other organs, the most common organs that we're talking about, as I said, the other lung, जो blood stream से ही पहुंचता है. ठीक है. There's brain, there's bone, for example, vertebral spine का TB बहुत common है. Even limbs में हमारे पास वहाँ पे एपोफिसिस पे जो एंड आर्टरीज हैं वहाँ पर हमारे पास टीबी बहुत कॉमन है. लैरेंजल टीबी इज द अदर सॉर्ट ऑफ पल्मोनरी टीबी के अलावा लैरेंजल टीबी हाईली ट्रांसमिसिबल है. लैरिंग्स में हमारे पास इन्फेक्शन कॉज कर सकता है, एंड देयरफॉर बिकॉज इट्स एयरवे, जरा सा भी बोलेंगे तो जो है वो हमारे पास एरोसोल्स जनरेट होंगे. सो जस्ट डोंट फॉरगेट कि वो भी होता है. द मोस्ट कॉमन साइट जहाँ पर टीबी इन्फेक्शन कॉज करता है और जो स्प्रेड करता है वो लिम्फ नोड है. सो नंबर 1 लंग, नंबर 2 लिम्फ नोड. ठीक है जी. और फिर उसके बाद बोन एंड ब्रेन एंड स्पाइन एंड किडनी एंड कोई भी दूसरा ऑर्गन हो सकता है, एनी अदर ऑर्गन it can be there. Everyone knows about abdominal TB जो हम उसकी बात कर रहे हैं. intestinal TB, intestinal से जो है वो हमारे पास omentum और ये सारी चीजें भी हमारे पास involve हो सकती हैं. So remember this कि a very small number can enter the bloodstream, and because bloodstream में enter कर गए हैं तो they can spread any part of the body, including areas where TB disease is more likely to develop, like brain, larynx, lymph node, lungs, spine, bone, kidney वगैरह. ठीक है. Now this, remember, is the extrapulmonary TB, right? यहाँ पर हमारे पास we were talking about pulmonary TB, but extrapulmonary TB is something जो के the only extrapulmonary TB, as I said, is जहाँ से बहुत easily transmission होती है वो है larynx, वो aerosol से transmit होती है. Otherwise जो है वो हमारे पास transmission aerosol से extrapulmonary TB की नहीं होती, and therefore if the patient does not have pulmonary TB only, which is जो उसके secretions में नहीं आ रहा है, वहाँ पर हमने pulmonary TB को wall off कर दिया है, लेकिन extrapulmonary TB है तो वो उसके अंदर हमको जो है वो infection control precautions और aerosol के precautions लेने की जरूरत नहीं होती. So let's talk about this. What is a granuloma? We know that it's a cardinal feature of the host response. There is, in particularly TB, there is necrosis or caseation in the center. Caseation क्या है कि जो necrosis है उसके अंदर बहुत ज़्यादा lipid component है, and that is what we call caseous material, right? And this lipid component जो है वो ज़ाहिर है acidic होता है, तो वो H&E पे जो है वो हमारे पास pink stain करता है. Right? अच्छा जी. And the other important feature are macrophages जो कि जो है वो specialize they can convert themselves into or transform into epithelioid cells, which are much more enlarged. They're spread. They're in a certain way, so that they can cover a greater surface area and sort of try and wall off. And epithelioid cells, when they fuse together, they form giant cells. And इसके अंदर बहुत ही particular type of Langerhans type of giant cells होते हैं, जिसके अंदर what do we see? A lot of them are fused together, and then the nuclei arrange themselves in a horseshoe pattern, right? And then, of course, there's a ring of your CD8 positive lymphocytes around these epithelioid cells, जो कि granuloma का component है. So you have special immune cells. They form a barrier or a shell, and the bacilli are in the center, and the shell breaks down. And if the shell breaks down, if the immune cells become lax or allow or they don't have enough support to keep walling it off, then the bacilli escape this granuloma, and they multiply and cause disease. Now let's look at let's look at the symptoms of pulmonary TB. Pulmonary TB ke symptoms are obviously the most important one. Pathognomic one is cough. We know that cough lasting more than 3 weeks or longer is 3 weeks or more, जो है वो with or without sputum production is a pathognomic feature of वो जो हम यही कहते हैं ना, टीबी सस्पेक्ट जो है, वो जो मरीज है, वो हमारे पास लॉन्ग ड्यूरेशन ऑफ कॉफ है. ठीक है. इसके सिम्टम्स में हमारे पास हेमोप्टिसिस है, which is coughing out blood in sputum है. There's chest pain simply because कि अगर प्लूरा वगैरह इन्वॉल्व होगा तो जाहिर है it will sensitize, it will stimulate the nerve endings and can cause chest pain. There's loss of appetite because of release of so many cytokines के जो है वो हमारे पास जैसे TNF alpha itself is something जो कि anorexia induce करता है centrally जाके. So there's that. There's unexplained weight loss because remember कि energy consumption हो रही है, oxygen की कमी हो रही है. Obviously metabolism is affected and therefore excessive weight loss. And of course there are cachexins being released due to the inflammatory response. And then there is certain constitutional symptoms like night sweats and fever and fatigue which goes on. I think ये तो MBBS ही नहीं पास कर सकते हम लोग जब तक हम टीवी के फीचर्स ना याद करें. तो I'm just we're just going over this again. So ये चीज हमें तो अच्छी तरह से पता है कि फिजिकल एग्जामिनेशन के बगैर आगे हम चल ही नहीं सकते. So evaluation पेशेंट का हम फिजिकल एग्जामिनेशन के साथ करते हैं. And yet physical examination alone cannot confirm or rule out TB. ये चीज याद रखनी है कि TB का diagnosis is never only on clinical suspicion. You have to have, in this day and age, you have adequate diagnostic tools. लैब के बगैर टीबी का नहीं होता. ये हम कहते हैं कि माइक्रोबायोलॉजिकली कंफर्म टीबी जो है वो हमारे पास टीबी का कंफर्म्ड केस होता है. अदरवाइज ऑल अदर केसेस ऑफ टीबी विल बी कंसिडर्ड टीबी सस्पेक्ट. ठीक है जी. अच्छा, साइंस हमारे पास कंफर्म वेट लॉस, बेसलाइन का हमें वेट पता है, कितने दिन में वेट लॉस हुआ है, ये सारा पता चल जाता है आपके पास. दूसरा, फिर चेस्ट एग्जामिनेशन में आपको जाहिर है वो सारी चीज़ें पता चलेंगी. ब्रोंकाइटिस, साइंस ऑफ कंसोलिडेशन, ब्रोंकियल ब्रीदिंग, ये सारी चीज़ें. देन प्लूरल टीबी में जो है वो हमारे पास फ्लूइड डिटेक्ट हो जाएगी आपकी उसके ऊपर. Obviously underlying clinical conditions बहुत important है. You should know comorbids क्या हैं पेशेंट के. अगर HIV का पेशेंट है या फिर जो है वो डायबिटीज का पेशेंट है या COPD या कोई ऐसी कोमॉर्बिड जो पोटेंशिएट कर सकती है डिजीज को, तो फिर हमें जो है वो रिस्क ऑफ प्रोग्रेशन ज़्यादा होता है and the probability of the disease increases. So let's have a look at certain chest abnormalities. We know कि यहाँ पर you can see certain cavities. Yeah, they're not filled with fluid, but you can definitely observe कि यहाँ पर cavities हैं और upper lobe में हैं, तो जो है वो हम cavities, highly suspicious of TB. This picture is of sorry. Okay, अच्छा मेरे arrows नहीं है. So this is miliary TB. You can say millet seed. बहुत बारीक बारीक आपके पास वो हैं. So these are all tiny granulomas जो कि अगर आप बायोप्सी करेंगे तो आपको दिखाई दे जाएंगे. Right. So let's confirm how to diagnose TB. How do you confirm TB? So obviously sputum है. In patients who are already producing sputum, जाहिर है उसके अंदर आपको induce करने की जरूरत नहीं है. उनका जो है वो productive cough है, you collect it. But if patients are not producing sputum, you can induce it through inhalation of hypertonic saline. ठीक है. So वो किया जा सकता है. या फिर now it's very easy, you can perform a bronchoalveolar lavage. But remember one thing कि ये situation जो है क्या है, it's not very biosafe, and if you want to ensure biosafety, that means कि जो भी perform कर रहा होगा bronchoalveolar bronchoscopy and bronchoalveolar lavage perform कर रहा होगा या gastric aspirate ले रहा होगा will have to be well protected. क्या है हमारे पास N95 mask, ठीक है. आपका आइज कवर्ड होनी चाहिए है, N95 मास्क होगा. आप बस नेगेटिव प्रेशर के अंदर ये चीज़ परफॉर्म की जाएगी. आपका जो है वो एनवायरनमेंट भी प्रोटेक्टिव होना चाहिए है. ठीक है. सो दीज स्पेसिमेंस कैन बी एग्जामिन्ड फॉर द प्रेजेंस ऑफ TB bacilli. And how do you examine them for presence of TB bacilli? You can perform smear हम आपकी परफॉर्म करेंगे because so we'll have and that's अब हम
Recording in progress.
It has phenol in it, and it is वही कहते हैं ना, उसके दोनों hydrophobic and hydrophilic ends होते हैं इसके दो. तो it like a vehicle के through dissolve होके ये enter कर जाता है सेल को, waxy cell wall को penetrate करके सेल के अंदर चला जाता है. And because of it अब जब हम एसिड से इसको डीकलराइज करने की कोशिश करेंगे तो एसिड विल नॉट बी एबल टू पेनिट्रेट द वैक्सी सेल वॉल, एंड देयरफॉर द tubercle bacilli, the mycobacteria will remain red even after decolorization with an acid. And then just to visualize the red bacilli better, we'd stain the background with a stain, with a color that will show the red bacilli better. और ये contrast में जो colors होते हैं वो या तो blue use किया जाता है या green use किया जाता है. And
Dr. Imraj, please mute.
So red या green background staining की जाती है, and that is why we say कि जो है वो हमारे पास background या counter stain is either methylene blue or malachite green. ठीक है. और जो red dye है that remains consistent, and that is your carbonyl function. The red dye कार्बन फुक्शन जो है वो हमारे पास ज़ील नील्सन स्टेन में भी यूज होती है और किन्योन स्टेन में भी यूज होती है. Now this is ज़ील नील्सन stain is something which uses heat to melt the wax and allow carbon fusion to enter. ठीक है. On the other hand, cold staining is quinone stain or quinone stain की सबसे important बात है कि it has a high content of phenol in it, much higher than the regular जो Zeel Nielsen में use हो रहा था, much higher content, and phenol जो है वो allow करता है being an alcohol, it allows the dye to enter. So just showing you कि जो है वो हमारे पास क्या and this is what it looks like. You have these nice red deep pink tubercle bacilli, बहुत thin होते हैं. As you can see, इनकी एक thin beaded appearance है. I don't know whether you are able to appreciate the beads. ये हैं, they're not very smooth. इनकी outline बड़ी smooth नहीं होती. You see that? They have this beaded appearance, and the background has been stained with methylene blue, so वो blue आपको दिखाई दे रहा है. The other acid fast stain जो कि develop किया गया है और has been in use, and it has revolutionized acid fast staining and detection of TB cases because it was fluorescent. तो वो higher magnification पे जाने की जरूरत नहीं है और आप lower magnification पे भी pick कर लेते हैं जल्दी जल्दी. And this is your auramine stain. Auramine is a fluorescent stain. Again, the vehicle is an alcohol, allows it to go in. और ये dark background पे होता है, या आप अंधेरे कमरे में या उसके ऊपर dark background पे करते हैं. इसके अंदर जो excessive stain है उसको remove करने के लिए potassium permanganate use होता है to dull the background, to background fluorescence ना रहे और जिसको कहते हैं कि stain particles इधर उधर ना चिपके रहें slide पे other than inside the bacilli. Okay, so this is something which has really revolutionized AFB smear. The other thing that you need to remember is कि quantify किया जाता है. Smear के ऊपर quantify करना is very very important. Why? Because एक तो ये कि जो है वो आपको ये पता चल जाता है कि transmissibility कितनी ज़्यादा है. The higher the number of TB bacilli on the smear, the higher the possibility of transmission of disease. A highly infectious patient होता है. And the other thing that you need to remember is, and of course that does not entail कि अगर हमारे पास जो है वो 1+ या weekly positive हैं, 1 to 2 bacilli या rare या scanty हैं तो patient transmit नहीं करेगा, because ये चीज याद रखने की है that it's intermittent secretion of वो. So if one sample has low bacilli, the other sample can have higher depending on कि आपने किस तरह से cough out किया है. And the other thing to remember is कि this can also be used to monitor response to therapy. ठीक है. For example, first week of diagnosis में अगर हमारे पास 4+ थे और 4 हफ्ते के बाद हमारे पास 1+ हो गए, तो we can see कि जो है वो your drugs are working and they have lowered the bacterial load. ठीक है. और अगर जो है वो smear negative होता है तो very likely हम ये कहते हैं ना, लाइफ में जो है वो कोई श्योरिटी नहीं होती है, probably the patient is non-infectious, and therefore आप जो है वो थोड़ा रिलैक्स कर सकते हैं कि अगर हमारे पास स्मेयर नेगेटिव हो गया पेशेंट, 2 स्मेयर्स नेगेटिव हैं, तो फिर हम जो है वो we can remove the आइसोलेशन जो उसकी एरोसोल आइसोलेशन है, अगर वो अस्पताल के अंदर है. अगर वो घर में अपने, तो भाई वो तो पहले ही से इन्फेक्ट किए हुए था ना लोगों को, तो अब उसमें टेंशन लेने की जरूरत नहीं है, उसको तोड़ दें उसकी जान. सही. अच्छा जी, कल्चर पे हमारे पास दिस इज व्हाट इट लुक्स लाइक ऑन लोवेनस्टाइन जेंसन मीडियम. दिस इज अ सॉलिड कल्चर. इसके अंदर हमारे पास ग्रीन कलर क्यों होता है? क्योंकि जो है इसके अंदर मैलाकाइट ग्रीन होता है. मैलाकाइट ग्रीन जो हमने डाई की भी बात की थी, but what happens is malachite green binds to bacteria, peptidoglycan, and therefore inactivates them, does not allow them to grow. So इसीलिए हम ये कहते हैं कि inhibitory होता है to other bacteria, right? And because it is inhibitory to other bacteria, तो हमारे पास slow growing mycobacteria हैं, वो फिर भी इसके ऊपर आसानी से grow कर जाते हैं because the nutrition is not taken up by other bacteria. अगर but of course before we inoculate on culture medium, हमारे पास samples have to be decontaminated before. Decontaminated का मतलब है कि हमारे पास दूसरे जो ओरल फ्लोरा है और ज़्यादातर ये पेशेंट्स जो हैं वो इनके एयरवेज बहुत अच्छा काम नहीं कर रहे होते, तो अक्सर ग्राम नेगेटिव्स वगैरह के साथ या ग्राम पॉजिटिव्स के साथ कॉलोनाइज हो जाती है एयरवे, तो उसको इनहिबिट करने के लिए हमको कंटामिनेट करना पड़ता है, विच मीन्स कि आप जो है सोडियम हाइड्रोक्साइड से उसको ट्रीट करते हैं, वो वाले मर जाते हैं बिकॉज माइकोबैक्टीरिया के ऊपर वैक्सी सेल वॉल होती है, तो माइकोबैक्टीरिया नहीं मरते. एंड उसके बाद डिकंटामिनेशन के बाद व्हेन यू इनोकुलेट कल्चर, तो कमेंसल्स और दूसरे बैक्टीरिया नहीं ग्रो करते और माइकोबैक्टीरिया के पास इनफ टाइम होता है, इनफ स्पेस होती है, इनफ न्यूट्रिशन होता है that they can grow. Right? The other thing which has also revolutionized ये 80s में हमारे पास this became 80s and 90s में जो है वो हमारे पास liquid culture for mycobacteria became the standard, okay, of TB diagnosis. And what we got was एक आपके पास solid culture medium होना चाहिए, एक आपके पास कम से कम एक liquid जरूर होना चाहिए. And liquid medium जो है वो उससे फायदा ये होता है कि जब वो it is faster, it doesn't take weeks, it takes days, 10 to 20 days for it to become positive. And the TB bacilli can grow in broth. Broth का फायदा ये है कि 360 सराउंड करता है, सिर्फ एक सरफेस नहीं होती, तो न्यूट्रिशन उसको हर तरह से मिल जाएगा एंड इट इज एबल टू ग्रो फास्टर. और जो है वो इसकी ग्रोथ की डिटेक्शन जो है वो उसकी फ्लोरेसेंस से डिटेक्ट होती है. सो दिस इज अ वेरी गुड वे. द थिंग इज कॉल्ड Mycobacterium indicator growth tube. ठीक है जी. So Mycobacterium growth indicator tube, MGIT, MGIT, Mycobacterium growth indicator tube. ठीक है. So it gives you faster results. Even susceptibilities can be performed in liquid culture, जिसके अंदर हम जो है वो liquid में certain concentrations of antibiotic डाल देते हैं and see के उनकी presence में as compared to growth कंट्रोल जो कि विदाउट एंटीबायोटिक होता है, उसके कंपैरिजन में इसकी ग्रोथ इनहिबिट होती है या नहीं होती है. और अगर इनहिबिट होती है तो इट इज कंसिडर्ड सेंसिटिव, अगर नहीं इनहिबिट होती इट इज कंसिडर्ड रेजिस्टेंट जी. सो बट नाउ द स्टैंडर्ड ऑफ जो इनिशियल हम डायग्नोसिस कर रहे होते हैं, सो वो हम पीसीआर बेस्ड भी कर सकते हैं एंड दिस इज मच मच फास्टर. व्हाई इज इट मच फास्टर? क्योंकि ये रियल टाइम पीसीआर है. 2 घंटे के अंदर 2 hours to 2 hours 45 minutes में हमें जो है वो पता चल जाता है कि टीबी है या नहीं है सैंपल के अंदर. एंड इट्स अ वेरी वेरी सेंसिटिव वे. इट इज बेटर देन स्मेयर. स्मेयर में हमारे पास जो है वो मतलब जिसको कहते हैं कि 1 ml के अंदर 1,000 to 10,000 bacilli होंगे तो they will show up on the smear. However, on this इसके अंदर हमारे पास जो sensitivity है वो हम load है वो about 100 to 150 bacilli in per ml पे ये डिटेक्ट कर लेता है. So this is what इससे भी ज्यादा sensitive वाला भी आ गया and that is called Expert Ultra, which can detect up to 16 bacilli per ml, and it is almost as sensitive as culture methods. ठीक है. So the best thing about Expert is it not only tells you whether TB bacilli or Mycobacterium tuberculosis is present in the sample, but it also tells you whether it is susceptible to rifampicin or not. Rifampicin susceptibility बहुत important है क्योंकि जो है वो rifampicin resistance is a marker for multi-drug resistance, which is isoniazid and and rifampicin resistance in TB. ठीक है, so I'm just quickly going to go over TB treatment. वही हमने कहा कि standard anti-TB therapy ATT है. आपके पास 4 first line drugs हैं, isoniazid, rifampicin, pyrazinamide, and ethambutol. और इनके 2 months के बाद जो है वो हम 4 months of the backbone of therapy, which is isoniazid and rifampicin, use करते हैं, and that is your treatment का वो 2 months of HRES and 4 months of HR, and that is your sensitive TB की treatment. On the other hand, अगर TB turns out to be resistant to both isoniazid and rifampicin, या फिर जो है वो expert पे RIF resistance detect होता है, which is a marker for multi-drug resistance, क्योंकि isolated RIF resistance is very uncommon, and that is why this is considered multi-drug resistant TB. ऐसी situation में हमें जो है वो we also have to resort to other drugs like apart from ethambutol, fluoroquinolones or amikacin, linezolid or bedaquiline add की जाती हैं, जो newer drug वो की गई है. And pre-XDR is अगर fluoroquinolone resistance भी detect हो in addition to multi-drug resistance. And इसके ऊपर भी अगर जो है वो if the isolate turns out to be resistant to linezolid or bedaquiline, then it is called XDR. ठीक है जी? I hope you know the definitions of MDR, pre-XDR and XDR. You should know this. So it's a disease which spreads easily. It जो non activity के साथ चीजें associated हैं वो हैं obviously no cough, no cavity, no AFB and smear, and the fact that it is extrapulmonary without pulmonary disease, तो ये जो है वो non-infectivity के साथ वो है, और ऊपर से you're not inducing any cough or lavage नहीं कर रहे हैं, ठीक है. और factors associated with this obviously are the fact कि या तो lung airway या larynx की disease है, या फिर जो है वो आपके पास smear पे दिखाई दे गए हैं bacilli, the patient is not responding to therapy, या aerosol generating procedures कर रहे हैं, positive sputum cultures कर रहे हैं, ठीक है. And of course the best way to prevent TB in the community is to detect cases and treat them, or treat with the right drugs, the right dose, and you have to ensure the patients are taking the drugs, and that is called directly observed therapy. DOTS कहलाती है. Of course, ensuring cough etiquette, right? Which is coughing in your elbow, covering your mouth, cheek, or obviously some patients will be sicker, and if they're admitted to hospital, तो airborne precautions के साथ admit करना होता है if they are infectious, right? And that means wearing N95. If you are the person, the caregiver, ये है situation. Care worker must be wearing N95. Patient should be wearing surgical mask. ठीक है? और negative pressure rooms होने चाहिए जिसमें जो है वो infected sucked out. How do you prevent? Vaccination बच्चों में क्योंकि first year में जो है वो TB meningitis and disseminated TB से prevent करता है, ठीक है. और जाहिर है बेहतर वैक्सीन्स की एफर्ट्स जारी हैं and to ensure कि जो है वो other populations, at risk populations में भी यूज हो सके. So I'm just going to be